Leslie and I are going to talk about some practical things, right? How you evaluate these patients, how you measure their progress. And we're going to talk about the CHOP INTEND, which is a measure for type 1 patients. And I know now that's fairly difficult to think about type 1, type 2, and type 3, but you can think infants, right? You can evaluate infants with this type of a scale. So here are disclosures. So to start, the idea is that we're going to think about how to use the CHOP INTEND as a way to measure your patients and also as a way to guide your rehab efforts with these patients. The plan for today is give you an overview of the testing parameters for each item. So we'll walk through each of the items and also to discuss the common observations that you might see in patients with SMA on each of the items. So Leslie has a couple of patients, a typically developing kid and a more severe kid. And then we'll walk through the items and look at one patient and how you progress through the scale. So there's a manual of procedures that's available online, and the score sheets are also available online. So as a background, these items were drawn from the Ames, the Peabody, the Bailey, some from the test of infant motor performance, and then also from your traditional neurologic scale. And then some also were created just for this assessment since these patients are so severe and move so little in the natural history state. We designed some items to look at anti-gravity movement in a variety of different ways. And the items were selected for their sensitivity, but also for the tolerance in infants, right? They have a limited capacity for getting moved around and bounced around in different positions. So we ordered the items in terms of how stressful they were, right? To make sure you got a good feel for the patient as you went along and didn't stress them out too much at the beginning of the assessment and left the more difficult, stressful items for the end. Our initial sample was based on only a little bit more than 20 infants, but now obviously this has been used in clinical trials and there's a good bit of understanding for how it performs in the SMA population and the larger neuromuscular population of weak infants also. It includes both active and elicited and reflexive items. So as the patient progresses in terms of age, you have to think about their primitive reflexes and the reflexive items, and you need to allow for active movement and postural reactions to take the place of their reflexive responses. So you're really looking for the motor outcome, whether you drive it by a reflexive movement like the gallant, or whether you drive it by a postural reaction based on the patient's position with respect to gravity. And the assessment is really divided up so that it looks at head and neck strength, trunk strength, in addition to proximal distal and distal limb strength. So like we talked about before, from easiest to most stressful, and then it includes gravity eliminated movement, which are the lower scores, and then anti-gravity movement, which are progressively harder scores. And all of the items are divided from 0 to 4, with 4 being the strongest and 0 being the weakest or least demanding. And in general, the patient should have 3 chances if they haven't achieved a full score. But obviously, you have to manage the child's tolerance also in amongst that. So if you have a kid that gets the highest score, you move on to the next one. You shouldn't press them. So variability due to fatigue is very important in this patient population. So we all know, when these kids get up first thing in the morning, they're bright-eyed and bushy-tailed, and if you catch them, right before they're due for a nap or right before they're needing to eat, infants are more fussy and less tolerant, and at the end of the day, they're going to be less tolerant. There's a fatigue component to patients with type 1 SMA also, right? So if they've been bounced around and they've been awake for a long time, they're going to be weaker. They're going to be different. Just like the patient with type 3 SMA, they walk up from the parking garage and you try to test them on the 6-minute walk test, they're already halfway through the test, right? So you have to make sure they've had a good rest, and if you get them when they're first waking up from their nap, that's you know, a good way to make sure you've kind of minimized the variability due to fatigue. You want to have a firm surface. You want to test them on a bed or something really soft. You know, it makes a difference in terms of their performance. You don't want to have restrictive clothing. And you want to have the best kind of toys and the things that's going to motivate them the best in order to get their best performance. And, you know, make sure their parents are around. Sometimes in, you know, kids that have stranger anxiety, this is a really important thing, right? You might administer the test fully out of their visual field, right? You want to have the parent's face occupy their visual field and have them not know that you're touching them, right? Because, you know, 2-year-olds are a little bit touchy, right? And sometimes it's better if the parent is there and interacting with them, and you can administer the item from off the side, right? When, you know, and kind of trick them into thinking you're not the one doing it, but that the parent is. And that's sometimes helpful for those behaviorally demanding patients. So here's the score sheet, right? There's 16 items, and it progresses from, you know, just watching the baby laying on the bed all the way up to the suspension items and the pull-to-sit items, which are a little bit more taxing, the vertical items where you have to sit the child up. So here's the first item. You're watching spontaneous movement of the upper or the lower extremities, right? And you're going to watch these throughout the test. So here you can see the child sliding his legs in a gravity-eliminated way, right? And also lifting his hands and elbows up off of the ground, but not quite getting his elbows free from the surface. For the children that are weaker than this, you can unweight their arms and legs, right? So you can get a view of their hands and how their hands move with respect to gravity, or how their ankles move with respect to gravity if the children are dependent because of friction with the surface. And obviously use a toy to try to get them to move the most they can. For item 3, this is administered by putting your finger in their hand. So the littlest kids will have a grasp response and will grab on. And you're really looking at how strong that grasp response is, or how strong their active grip is. And you're using the weight of their arm and the weight of their shoulder to kind of grade this. So you could test this here too if you want. Right? So while the child's sitting up, you could use this position to test the next item, or you can put them to the edge of the mat like I'm going to do here, and block one leg so they don't slide forward, and then test the opposite one, and then switch your position and test the opposite side. So here you see we're testing the quads to see whether they kick their leg forward in this position. Give them a little bit of stimulation, and then you switch sides and kind of provide support for the other side, and then watch them kind of kick their leg. So this is a suspension item. You can do this like this, right? I'm holding the child's head and trunk with one hand and bracing them against my body and letting their pelvis and legs dangle. For older children, it might be helpful to have the parent lift them up off of their knee under their arms, and then you can stand in front of them and evaluate their legs. And what you're looking for here is to see whether you have anti-gravity motion of the legs. So you're looking to see if the children retract, bend their knees, bend their hips. Right? So you pick them up. You can put your chest against the child for the older children, and then you kind of have a secure position to lift them in. So this is a head control item, right? And this is done in either 2 or 3 parts. So the first part is to see whether you can get head control in supported sit, right? So the first thing is to see whether the child has good head control sitting up, right? You get them lined up as best as you can. Okay? And then if they can't get their head control good in a vertical position, you lean the child forward a little bit and you see whether they'll maintain a position with their head in a little bit of extension. What we know as therapists as a stacked position, right? You lean forward, they stack their occiput right on their shoulder girdle, and some children will be able to maintain that slightly extended position. If they can't do that, then you're going to allow their head to fall forward on your thumbs, right? And then you're going to see whether they try to lift their head up into extension, whether they have kind of active motion. And some children will rotate their head a little bit. Other children will make an effort to go straight back. And then other children will just sit there with their chin on their chest. And you'll see their breathing. Their head will move up and down with their breathing, but they won't make an active attempt to lift their head beyond their breathing. Right? So it's important to see whether it's active muscle action around the neck or whether it's just because their chest is rising or falling. For the strongest kids on the other end of the scale for this item, once they've maintained head control and they have good head control in midline, you can try to flex their head and see whether they're strong enough to lift it all the way back up to a neutral position for the highest score on this item. So items 13 and 14 are these pull to sit items. Okay, so here you pull at you hold the infant in their hands or around their wrist, and then you provide traction until the head just barely comes off, right? So you don't have to pull the child all the way to sit if they don't have head control. They can still be supported there, but you need to get their shoulder girdle off of the mat, and their head needs to be contacting the mat. And then you wait to see whether they try to pull with their arms or whether they tuck their chin, right? So if they have active contraction of their elbows, but they don't really flex their elbows, you get a partial score. If they actually have some elbow flexion, you can get a full score on that item. And then you look at the head and neck. Do they make an attempt to contract their sternocleidomastoid or to rotate their head back and forth, kind of struggling to kind of lift their head up? Or do they actually bring their head forward all the way off of the ground for a full score? So this is the Landau. So for an infant, you want to hold them kind of over along their rib cage and then wait and see whether they lift their head up off of the ground. For the children that are bigger, that are a little bit harder to lift, you can have their head in contact with the ground and their knees in contact with the ground if you're uncomfortable kind of lifting them all the way up off of the ground. But you need to provide enough traction for their head so they feel a need to try to lift it. And then you provide a firm stroke along their paravertebral muscles to try to get them to encourage them to lift their head up off of the ground. Obviously, here's a child with good head control and able to lift their head up off of the ground pretty readily. The last item is the gallant. So you're going to hold the child in the same position, in this suspended position, right? And you support them at their lower thorax across their rib cage. And then you have to provide a firm stroke along their paravertebral muscles to encourage that kind of lateral deviation of their pelvis back and forth. Now, you know, we all learned in PT school, for those of you that are PTs, right, that this disappears, right, around 6-7 months, right? So what you're going to think about is, okay, this is a reflexive item. Once it disappears from our reflexive repertoire, then we're going to try to use either active motion or you're going to use postural reactions to try to see if the child can recapitulate the thing that you saw earlier, right? Their gallant response in an active way or a postural reaction sort of way, right? So you can tickle along their sides, or you can tip them to the side, or for even the 2-year-old, you can say, can you dance or can you wiggle your butt, right? To get them to kind of wiggle their butt back and forth, and you can give credit for that also. Okay. So that's a walk through the items. I think Leslie's got some videos to show you of a couple of different kids of different severity.
All right, thanks, Allan. So we thought it would be nice to have a couple of different videos. The first video is actually of a typically developing 2-month-old. I think this is kind of relevant from a standpoint of some of our so-called pre-symptomatic babies that we may be seeing. So that's something that I think would be helpful for us to kind of look at. So again, we'll go through the items and kind of just talk through, not necessarily to grade or talk about what we would score this baby, but really just to get a sense of what we're looking for. So items 1 and 2, remember, are just observation. You're looking to see whether or not the limbs are coming off of the support of the table. I think that obviously in your stronger kids, you see this pretty readily right away, where you sometimes need to be a little bit more patient. It's going to be in those weaker kids, and we may see that a little bit more in the second video. Hand grip is one that can be difficult in a stronger child, just because there's so much movement trying to get them to actually grip when they're down to their side. And then once they're down to their side and have attained that grip, then applying that traction through to see whether or not they maintain the grip with the hand off the surface, with the elbow and the shoulder off the surface, like so. So again, just looking to see how strong the grip is. I think on that one, it's sometimes difficult to determine where does the grip actually, when do they actually lose the grip? Because when you get them at that very end range, sometimes I have a habit of maybe pulling a little too far, a little too hard, so they can't maintain the grip. So just being aware of kind of the range in which you're taking them can sometimes affect that item a little bit. Okay, so item 4 again is head and midline. Again, with a strong baby, trying to get them to maintain midline. You've got to be ready and have that toy ready in order to be able to get them to focus and maintain for those 5 seconds that you need them to maintain. If you can't passively get them into rotation, you can have them actively follow a toy or follow your face in order to get them into that rotation, and then seeing if they're coming back to midline. The ever popular name badge. So again, Allan mentioned you do want to remove the diaper in making sure that the diaper is not pushing the legs out. In this baby, he's strong, so legs come up right away, and when those legs come up off of the surface, that's your highest score. So you're looking to see whether or not they either come off the surface or maintain the position for 5 seconds. Rolling is when the kids start to get a little fussy with me. I think they're starting to have had enough of me, and so this is where sometimes trying to keep them happy through the items is sometimes difficult. You're going to assess rolling to both right and left, and then as well looking at rolling from the arms. Again, in these typically developing babies, in our stronger babies that we're going to be seeing, I think this is a really common, this happens to me all the time. When you go to apply that traction, they just kind of, they follow, right, and then come forward. So you're looking for that head righting response for the highest score. And I think in the second video, we'll be able to show you kind of again, this is one where you sometimes have to have some patience and allow some time for them to complete the item. Okay, the side lying, looking to see whether or not that arm comes off of the body and reaches into either horizontal abduction or abduction, which is obvious with this one. It really didn't really even need much from a standpoint of a stimulus with a toy for reaching. It just kind of happens automatically in these stronger babies. And then again, Allan does an amazing job of assessing these kids while holding them. I need parents to help me. So I typically have the baby in the parent's lap, and then I'm in front of the baby trying to assess. But Allan's the master at this, so that's why he can do it so well. So this is, he mentioned this was an example of, he had in the very first video, the baby was sitting on the edge of the table. Here he has the baby over his lap. I think that's the thing to think about here is just as if we talked about with the arms not restricting movement in the upper extremity shoulder flexion item. For item 10 for knee extension, you'll want to make sure that whatever surface they're on is not restricting your movement as well. So if you have them too far up on your thigh or on the parent's thigh where they don't have enough range to move, then that's not good. So you want them, supported, but in a position where they have free range of the leg. The other thing is it's nice to be able to put them in kind of a 90-90 position so that you can really see, because you're grading this on the degree of extension at which the child obtains. And so being able to really visually see that true knee extension at a 90-90 position is sometimes really important when I'm looking at grading this item. Okay, and then this is awesome. You see hips and knees flex. I think what I see, you'll see more in our babies with SMA. You're going to see more knee flexion than you will hip flexion. That's in my observation. The other thing is a lot of times you have to be careful with these kids that your knee flexion and knee extension, when we're looking at those, are not recoil or rebound from a previous position. So you want to make sure that it's actually active movement and not just a passive response to whether or not they've flexed and they're extending. And then the head control item. Allan does a really nice job in this video of supporting the trunk. So you want to be supportive around the shoulder girdle to allow them that best, to be able to have the best support in order to focus on head control and not trunk control. And so looking to see how the baby responds there. So the traction item, obviously this baby has good control, and so we'll go back to that. You can see obvious flexion in the elbows and good head control. So nice to see that. And then the prone suspension items, Gallant and Landau. So a firm stroke from coming up from the caudal to rostral, thank you, is important, and then also just that support. So that's a typically developing baby. And then what we have next is we actually have, this is a 13-month-old male. He was a baby with 2 copy counts of SMN2. His symptom onset was at about 3 months of age, and then he began commercial Spinraza dosing at about 5 months of age. At the time of this video, he had been on treatment for 7 months, so he had completed his 5th dose of Spinraza. So we'll take a look at this little guy. He happens to be one of the cute. Why are kids with SMA so cute? So items 1 and 2, trying to get some movement of the upper extremities, looking to see, does he reach off of the surface? Whatever toy I can find, trying to get him to be to reach and look, and he does attain a full score with his upper extremities. He's able to reach off of the surface. So for lower extremity, being able to trying to stimulate to apply a stimulus, tickling, whatever, moving, whatever you can do to try to get some movement. Looking to see whether or not there's ankle movement, whether or not there's knee movement in a gravity eliminated position or against gravity. Just trying to get any kind of movement that you can. So there, for a minute, supporting the. Allan mentioned you can support the limbs in order to kind of see if you can get more movement. But there's some ankle movement with this little guy. So, and there's a little bit of internal rotation of the hip. So, a little bit of movement there. Sister likes to help. So again, you can use a pen, you can use your finger. This video is always a fun one because he won't let me. He's actually pulling back. He's not letting me fully extend, so so I can't get that full kind of extension through the shoulder. But there's definite grip strength there. So looking to see, does he maintain midline? This is are we still on item 4? Because he's rolling, trying to make sure. So if that is something with our stronger kids, to try to disassociate rolling with that head, with that cervical rotation, is sometimes difficult when they're stronger. So they'll actually rotate their whole body instead of just at the cervical spine. So that's sometimes a difficult kind of position with this item. So you have to kind of look to see. I think it's fine to try to stabilize at the trunk if you need to, and then really look to see what's happening just at the cervical spine. Okay. So I do not remove the diaper in this video, but basically it's because he achieves a full score. So the diaper is not hindering his performance. So that's my justification for not doing that. So I'm looking to see, does he maintain that position? So again, trying to apply traction. And then again, like Allan mentioned, there's that pause that you have to wait and see what's happening. Does the head turn? Does the arm come through? And using whatever you can to kind of get some movement. So now this baby has rolled into a vertical position. So now you're going to continue to try to get, and there's still a little bit of traction being applied, trying to use the toy to try to get him to continue the roll. So whether that he gets into prone and actually clears his arm is kind of what you're looking for there. Sister was sometimes a hindrance and sometimes a help. It just kind of depended. The other thing about these videos is I'm obviously not in the best position. It would be better if I were on the other side of the baby. Part of that is because I'm trying to stay out of the way of the camera. But thinking about where your position is, where mom is to help with facilitating that role and giving them some kind of stimulus for rolling. So again, not the best position for me to be in behind the baby. I would probably move myself forward in front of the baby to do that a little bit better. So he's not gone prone, and his arm is still underneath his body, so he would be a 2. But he did come through vertical. So there's a wide variety of a 2. A 2 is anything that comes into vertical, all the way to prone with the arm still under the body. So they have to actually clear that humerus in order to get the next score of a 3. So then rolling from the arms, same kind of concept. So again, not a great, I wish I were in a better position in front of him, but looking to see if we can get that roll. Sometimes I'll take them back into supine and start again. Like Allan said, give them 2-3 tries. Sometimes if you reset, that you can get a little bit better of a response. And then mindful of tubes, G-tubes, anything that tubes and lines you have to be mindful of in these items as well. Okay. So lying on his side, this is sometimes a tricky one, just getting them positioned just like this from a standpoint of he's rolling his trunk, rotating his trunk, and I really don't ever get his arm in that nice position with a little bit of extension and some elbow flexion, but he still reaches. So I'm still going to give him that score. I'm doing a little bit better there, trying to get him where I want him, and then looking to see what happens with the arm. And he has a nice reach and is able to get a full score. Okay, so now these are, he's a little bit reclined, looking at shoulder flexion or abduction. I think because I use the parents and the caregivers and whomever, your education and teaching them how to handle is important. So here again, I've got him in that 90-90 position so that I can really see whether or not there's extension at the knee or not. So he's an older, larger kid, but she does a really nice job of keeping him supported, keeps the hips free and not restricted, so that I can really see whether or not there's some knee or hip flexion there. I think the one thing I've learned from a couple of other evaluators is if you've got a larger child, actually putting them sitting on the edge of a plinth and putting them sitting on the edge of the plinth with the leg hanging over is okay, as long as the hip and knee are free from the surface, so that if you need to kind of help support a larger, bigger child that you can't really hold, that's another little tip that another evaluator taught me at one of our trainings. So head control. He is able to look down and look up. And now just looking to see if he moves around freely, maintains that head in a nice midline position. Okay, for sake of time, just so we have time for questions, I'm going to move forward. Okay, 13 and 14. So I don't need to keep pulling him all the way up. I mean, you do just because he was okay with coming up, but I would not need to do that. And then prone suspension again in a bigger kid. This one's difficult trying to get. Now I'm just using verbal stimulation to try to get him to raise his head. And then he should be unweighted more on this one with looking at. But I'm just trying to get in here. I'm looking to see just can I get active movement, like Allan said. If it's not, it could be a positional response. So trying to take him into a tilt to see if he responds from a positional standpoint is an okay way to do that too. So hopefully those videos were helpful to kind of see a couple of, we saw 3 kids and take them through with varying levels of function. So what questions do you guys have at this point? Allan, you want to come up? Oh, actually, you know what? I think I have one more slide, but you can come up still. So common challenges. We talked a little bit about this already, just managing lines, suction, and other medical complications, having parents there to make sure that they are getting suction if they need it, or if they need a rest, if they need some comfort from mom and dad, and those kinds of things. Those bigger, heavier kids, again, just trying to find ways so that you keep them supported and still and still administer the item as best you can. And then one thing I didn't mention in the older kids with the grasp and the rolling, they'll actually start to resist you with your facilitation. So you'll go to try to get them to grasp your finger or a pencil, and they'll just push you away. So those can be difficult to administer in your from a behavior standpoint. And same thing with rolling. I've had several kids who will actually de-rotate as I'm trying to facilitate rotation through that rolling. So those are often challenges that you have to deal with.
Yeah, so if they resist rolling, you can score an active roll too.
Yeah.
So, if the child rolls to their stomach, you need to watch how their head goes, right? And if they can laterally flex their head, you can give them a full score based on their active rolling also. Some children that actively roll all the way to prone won't be strong enough to lift their head up, and their head will just kind of roll over the weight-bearing arm, and they'll get a 3 for that type of a score.
So questions?
So there's a manual online, and there's a score sheet online that you're welcome. Yeah, there are pictures in the manual, but there aren't videos. No. So, I have permission to show videos of the children during training and for teaching, but I didn't get permission to post them online. So
I think we're aware that there is a need for some online training materials and things, and there are some things being done in the background, just nothing available at this time.
Yeah, we have a step-in group that's working on training and dissemination for this and the other outcome measures, and also training for care for kids with SMA in general. So we're working on that, but not quite all the way there yet.
So hang in there.
Yeah, but step-in would be the way to search for that once it comes around. I think we have a website already, but it's pretty bare bones.
Yeah.
It's maybe live as of this month.
Yeah.
Last month, something like that.
Yes.
Can you speak a little bit about modifications for patients with trachs and also hip or
Yeah.
So the question was, can you speak to modifications for children with trachs and or with hip or shoulder subluxations? I think that I'll just start with the rolling items from the standpoint of the subluxation. I think that Allan has taught me that it's okay to, you can place your hand kind of behind the shoulder girdle or at the hip girdle to monitor that and apply some support there to try to help with those kinds of, with those items for sure.
Yeah. So I got that. So part of the motivation for this is the traction that goes on in the arm and the traction that goes on in the leg. So if you feel uncomfortable providing enough traction in a larger child because of the weight of their trunk, you can provide the traction, make sure you kind of get that feeling of traction so the child has something to pull against, but then also provide some of the support at the shoulder to get to that vertical position of the shoulder girdle. The leg, I think, is a little bit less of an issue, right? You shouldn't feel uncomfortable providing traction at the leg and bringing the hips vertical. As for the trach, you have to be comfortable with what you do, obviously. Personally, I feel much more comfortable handling a child with a trach than I do with a respiratorily demanding child without a trach. And I'm much more careful for the patients that are BiPAP dependent and sprinting while I'm evaluating them. You have to watch their face and you have to know that they're not going to cry out loud because they don't have the respiratory capacity to produce the volume. So you have to know, how they're taxed, and you have to watch their saturations and all the other things.
The other thing, sorry, Allan. Go ahead.
But the trach, mostly it's about not pulling the trach out, and that you should be able to manage, right? Even in prone, you should be able to handle that.
In those kids that do have those respiratory challenges, I do try to put the parents at ease as well, because they can be a little bit concerned when you go to put them in prone suspension and, what are you doing to my child? So I often will kind of guide them and say, this is what I'm looking for. I'm monitoring their respiratory function. I'm monitoring, I'll keep them safe. And so giving that comfort to the parents is sometimes an extra step that you need to potentially think about.
So when you're doing the prone suspension item, if the child has a little bit of respiratory compromise, these children are dominant diaphragmatic breathers, right? So putting your hand on their rib cage is important and not kind of restricting their abdomen, right? If you put them in prone and they can't expand their abdomen, then they become, agitated because they can't really breathe in that position. But as long as their abdomen is free, they do pretty well.
Okay, I think our time is up. So thank you guys very much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.